Good evening, folks. Welcome to SUPERPoints Master Class. We are discussing USMLE and NEET, FMG, these important examinations, most important questions. Today I want to discuss some recent questions from pathology. Let us see this question. A 68-year-old woman presents with progressive fatigue and lower extremity swelling over the past 3 months. Physical examination reveals bilateral pitting edema and jugular venous distension. Echocardiography shows concentric thickening of the ventricular walls with diastolic dysfunction. An endomyocardial biopsy is performed and sections stained with Congo red show amorphous eosinophilic extracellular deposits on light microscopy. Under polarized light, the deposits display apple green birefringence. Which of the following best describes the ultrastructural appearance of these deposits on electron microscopy? So there are 4 options given under this question. Please go through these options and choose your best answer. Then we will discuss this question. So the correct option here is option C. Why is that? Option C is correct because this question describes amyloidosis. Let me give you this illustration. So in amyloidosis, what is happening is amyloid fibrils, they are being arranged as beta sheets. Amorphous hyaline deposits that stain with Congo red. So this that is an important point. They stain with Congo red. That's a very good clue. And also apple green birefringence under polarized light. So that's another important clue that this is amyloidosis. What is amyloidosis? Amyloidosis is a group of diseases caused by misfolded proteins, amyloids, that deposit in organs like the heart, kidneys, liver, and nerves. What are the symptoms? Fatigue, swelling, weight loss, shortness of breath, numbness, organ dysfunction, depending on the affected area. So amyloidosis can happen in any organ, okay? It can be in the brain, heart, liver, kidney, intestines. So in amyloidosis, amorphous hyaline deposits stain with Congo red, and under polarized light, these deposits display apple green birefringence. On electron microscopy, the deposits are arranged in a beta pleated sheet configuration. So that's the most important things I wanted to tell you about. When you diagnose this condition on light microscopy, you're seeing amorphous eosinophilic extracellular deposits, Congo red stain, you're seeing apple green birefringence under polarized light. On electron microscopy, you're seeing non-branching fibrils measuring 7.5 to 10 nanometers arranged in beta pleated sheets. So this question came on that point. What do you see on electron microscopy? So that is the correct answer. In cardiac involvement, amyloid infiltration stiffens the myocardium, producing diastolic dysfunction and restrictive cardiomyopathy as seen in this patient. How do you remember? So the mnemonic, super mnemonic here is amyloid is 3 B's. Right? Remember like that. Amyloid is 3 B's. It is beta, birefringent, bundled fibrils. All right. Beta is for beta pleated sheet structure. Birefringent is for apple green with Congo red. Bundled fibrils 7 to 10 nanometers, non-branching fibers on electron microscopy. What about the incorrect answers? First of all, what about A? Randomly arranged thin actin and myosin filaments. Actin and myosin filaments are intracellular contractile proteins found in muscle sarcomeres and are responsible for muscle contraction. Amyloid, in contrast, is an extracellular protein deposit composed of misfolded proteins. So, amyloid is an extracellular protein deposit composed of misfolded proteins arranged in beta pleated sheets. So it's not about muscle filaments. What about B? That is granular electron dense immune complex deposits along the basement membrane. Immune complex deposits are seen in conditions such as membranous nephropathy and appear as granular electron dense material on electron microscopy. Amyloid deposits differ in that they form non-branching fibrils with a characteristic beta pleated sheet structure rather than granular immune complexes. So there are no immune complexes here. Okay, that's a different story, like systemic lupus erythematosus, those disorders. But here you don't see that. What about D? Membranous whorls of myelin-like material. Membranous whorls or myelin figures represent accumulated lipid within lysosomes. They are characteristic of lysosomal storage disorders such as Niemann-Pick or Fabry disease. Okay, so you see those in Niemann-Pick or Fabry disease. Amyloidosis involves extracellular protein fibrils, not intracellular lipid accumulation. So, what is the key exam takeaway? The key exam takeaway is amyloid is extracellular, non-branching, beta-pleated sheet fibrils, not muscle filaments, immune complexes, lipid whorls, or drug-induced inclusions. So they would want you to know about the pathogenesis of amyloidosis. It's not about intracellular deposits, it's not about muscle filaments, it's not about immune complexes, it's not about lipid whorls or drug-induced inclusions. This is about extracellular, non-branching, beta-pleated sheet fibrils accumulating in different organs of the body and causing different disorders based on the site of deposition. All right. What about the super formula? Super formula is you see keywords, a few keywords, and you arrive at the answer in a few seconds. All right. So here the keywords are amorphous hyaline deposits, stain with Congo red, display apple green birefringence under polarizer light, 7 to 10 beta plated sheet fibrils. So if you see those words, hyaline deposits and they're staining with Congo red, apple green birefringence, and then beta pleated structures, you know very quickly that they are talking about amyloidosis. All right. So the point is, this is something you need to put to your memory. That is, in amyloidosis, light microscopy shows amorphous hyaline deposits that stain with Congo red. Under polarizer light, these deposits display apple green birefringence. On electron microscopy, the deposits consist of non-branching fibrils measuring 7.5 to 10 nm in diameter, arranged in a beta-pleated sheet configuration. So that's a very interesting question. In fact, we have discussed all possible ways you can get a question on amyloidosis. So next, let us do this question. A 72-year-old man dies from progressive heart failure. Autopsy reveals aortic valve leaflets that are thickened, rigid, and studded with calcified deposits. Histologic examination shows basophilic granular deposits on the valve cusps. Laboratory studies during his final hospitalization showed normal serum calcium and phosphate levels. Which of the following best describes the pathologic process underlying this patient's valve changes? So there are 4 options here, and choose the best option that you can give. All right. So the best answer here is C. Calcium deposition in damaged tissue despite normal serum calcium levels. So basically this is about dystrophic versus metastatic calcification. So pathologic calcification, that is the topic here. Take a few seconds to think about topic because that makes everything clear. Pathologic calcification refers to the abnormal deposition of calcium salts within tissues and is an important mechanism of chronic tissue injury and organ dysfunction. It occurs in two distinct forms based on serum calcium status and tissue integrity. Dystrophic calcification occurs previously damaged or necrotic tissues despite normal serum calcium. So when you see normal serum calcium and calcification, they are talking about dystrophic calcification. So it is commonly seen in areas of chronic inflammation, necrosis, atherosclerotic plaques, and aging cardiac valves. Metastatic calcification occurs in normal tissues due to systemic hypercalcemia. So whenever there is hypercalcemia, whenever you see the calcium level is high, that is metastatic calcification. Okay, typically caused by disorders such as hyperparathyroidism, malignancy. That can be like a paraneoplastic syndrome. When you have a malignancy, hypercalcemia, and then that is causing metastatic calcification, then it can be vitamin D excess. So in this patient, progressive thickening, calcification of the aortic wall with normal calcium indicates dystrophic calcification, a degenerative process resulting from chronic mechanical stress and tissue injury. This leads to stiff, non-compliant valve leaflets and ultimately contributes to aortic stenosis and heart failure. So this dystrophic calcification happening with normal calcium can result in aortic stenosis and heart failure. All right? How do you remember these things? Supermnemonic comes to our aid. The one I used for my exam is dysnormal, meta high. Dysnormal, meta high. How do you explain this? Dystrophic calcification, you have normal calcium, right? That is dysnormal. Then metastatic, meta high. Metastatic calcification, you have high calcium. The other way you can remember this is what is happening in malignancy. Paraneoplastic syndromes can happen. Hypercalcemia can happen. And hypercalcemia can cause metastatic calcification. So that is also one way to think about it, because there is a hypercalcemia and metastatic calcification. In the other thing, in dystrophic, you have normal calcium. So that is also another way to remember this. What about incorrect answers? Let us say calcium deposition in necrotic tissue due to metastatic calcification. Well, metastatic calcification occurs in normal tissues due to hypercalcemia. Calcification of damaged or necrotic tissue with normal calcium levels is dystrophic, not metastatic. Then calcium deposition in normal tissue due to hyperparathyroidism. Hyperparathyroidism causes metastatic calcification from elevated serum calcium, typically affecting normal tissues such as kidneys, lungs, gastric mucosa. This patient has normal calcium levels. Because this patient has a normal calcium level, making this mechanism unlikely. Next, calcium deposition due to metastatic spread of calcified emboli. Valve calcification does not result from embolization of calcium deposits. Instead, it develops from local degenerative injury and chronic mechanical stress consistent with dystrophic calcification. So the super formula here, like how can you arrive at the answer? By looking at a couple of keywords. Whenever you see there is chronic tissue damage, whenever you see normal serum calcium, all right, then calcium deposition, they're talking about dystrophic calcification, all right. And super point here is dystrophic calcification occurs in damaged or necrotic tissue despite normal serum calcium levels, classically seen in aging or chronically injured heart valves, atherosclerotic plaques, and areas of prior inflammation. So that's a very, very important question, folks. Please remember that. Let us go to the next one. A 52-year-old man with a long history of heavy smoking undergoes bronchoscopy for evaluation of chronic cough, and hemoptysis. Biopsy of bronchial mucosa shows disordered epithelial cell growth with nuclear hyperchromasia, pleomorphism, loss of polarity, increased mitotic figures confined to the epithelial layer without invasion of the basement membrane. Which of the following best describes this lesion? Hyperplasia, dysplasia, metaplasia, anaplasia. Choose one of the four options. So the best one here is dysplasia. Why? First of all, what is the topic? Dysplasia is pre-malignant epithelial change in carcinogenesis. Dysplasia refers to disordered atypical proliferation of epithelial cells that represents an early pre-malignant stage in the spectrum of carcinogenesis. It is characterized by loss of normal cellular architecture and cytologic atypia. So that's the very important point. You will see nuclear hyperchromasia, pleomorphism, increased mitotic figures, loss of polarity. Importantly, these abnormal changes remain confined above the basement membrane. All right. How do you distinguish dysplasia from invasive malignancy? Dysplasia is confined to the basement membrane. Malignancy is invading. All right. That's a very important point. Chronic irritation or inflammation, such as long-term tobacco smoke exposure in the bronchial epithelium, can induce progressive epithelial injury that evolves from metaplasia, dysplasia, carcinoma in situ, invasive carcinoma. So metaplasia becoming dysplasia, that is becoming carcinoma in situ, and that is becoming invasive carcinoma. So dysplasia is considered potentially reversible if the inciting stimulus is removed, but persistence increases the risk of malignant transformation. Thus, in smokers with abnormal bronchial biopsies showing atypia without invasion, the most accurate diagnosis is dysplasia, a key precancerous lesion. So dysplasia is disordered but reversible epithelial growth. Anaplasia, irreversible, undifferentiated malignant change. What is the supermnemonic? How do you remember this? This is what I use. Dysplasia is dirty cells that don't die. Right? That is the mnemonic I used to remember. Dysplasia is dirty cells that don't die. They are bad, but they don't die. They don't invade the basement membrane. Now, what about the incorrect answers? What about hyperplasia? Hyperplasia is an increase in the number of normal cells due to physiologic or hormonal stimulus. Cells maintain normal architecture and no cytologic atypia, unlike this biopsy which shows pleomorphism and hyperchromasia. So, pleomorphism and hyperchromasia, you do not see those in hyperplasia because hyperplasia is normal cells. And metaplasia is reversible substitution of one mature differentiated cell type for another. Although adaptive, the cells remain cytologically normal, not atypical or disorder as seen here. What about anaplasia? Anaplasia refers to complete loss of differentiation and a feature of frank malignancy. It is associated with invasion and aggressive behavior, which is not present because the basement membrane remains intact. All right. So, super formula here. How do you identify this? All right, based on a few keywords. If you remember super formulas, you can answer these questions in a few seconds. For example, if you see pleomorphism, hyperchromasia, and confined above basement membrane, if you see those three keywords, you can go directly to dysplasia. All right. Try to remember those keywords. Every question is about keywords, and every examiner has to rely on those keywords. Otherwise, he would be all over the place, right? He wants to be specific, and specificity comes from unique features, which are keywords. So the keywords here are pleomorphism, hyperchromasia, and confinement above basement membrane. That's why it's dysplasia. SUPERPoint here is if atypical cells are present but the basement membrane is intact, the diagnosis is dysplasia, pre-malignant, potentially reversible. Alright folks, that's a very, very important pathology question. Please take time to understand these cellular changes, because definitely you will get a question on this. Alright. Next, let us go to this question. A 45-year-old woman is evaluated for an enlarging breast mass. Biopsy reveals invasive ductal carcinoma. Immunohistochemistry shows overexpression of cyclin D1. This tumor most likely has dysregulation at which are the following points in the cell cycle. Alright, we have I gave actually 5 choices, and choose the best option. So the best answer here is G1 to S transition. Alright. This is basically a cell cycle regulation, cyclin D1 and the G1S checkpoint. The cell cycle is a tightly regulated process that governs cellular growth, DNA replication and division. Progression through each phase is controlled by cyclins and cyclin-dependent kinases, which act as molecular checkpoints to ensure that damaged or unprepared cells do not divide. Among these checkpoints, the G1S transition is the most critical restriction point where the cell commits irreversibly to DNA replication. The best way to remember this is remember this diagram. Okay, that's what I do. This always confuses me. G0, G1, G2, what is happening? So I remembered this one diagram. So from G0, you are going to S phase, okay, G1 phase and then S phase. So cyclin D, all right, where is it acting? It is here, folks, G1 to S. All right. In S phase, DNA synthesis happens. DNA replication happens here. So before this, there is a checkpoint like, well, you are going to create lots of DNA and let me make sure that everything is good. So it's like a proofreading. It's like a checkpoint. It's a restriction point. Imagine like a police stopping everybody at a border, okay? They don't want to let anybody in. So these are like cyclin D is like that. If it sees any bad cell, they will stop it. If they see a good cell and everything is good, then you go ahead to DNA synthesis like that. So then comes G2. This is preparation for mitosis, final growth and activity before mitosis. Then G2 checkpoint is also there. Okay. Then after G2 checkpoint, we have metaphase checkpoint here. And we have mitosis and cell division happening. Prophase, metaphase, anaphase, telophase happens there. And then going back to Z0. So cell cycle, the best way is to remember this diagram in your mind. That is the best thing you can do about it. So cyclin D1 in complex with CDK4/6 phosphorylates the retinoblastoma protein, releasing E2F transcription factors that activate genes required for S phase entry. Overexpression of cyclin D1 bypasses normal growth control and DNA damage surveillance, forcing premature progression into DNA synthesis and resulting in unchecked proliferation, a hallmark of many cancers such as breast carcinoma and mantle cell lymphoma. Thus, tumors with cyclin D1 overexpression primarily exhibit dysregulation of the G1S checkpoint, the key gatekeeper of cell cycle control. So the mnemonic, if you want a mnemonic, the super mnemonic here is cyclin D is door to S phase for DNA synthesis. Just blindly remember that. Cyclin D is door to S phase for DNA synthesis. Cyclin D is the regulator all right, and it is the door checkpoint gate concept, all right, perfect metaphor for cell cycle control, and S phase where it leads to DNA synthesis. And what about incorrect answers? Incorrect answers are here: G0 to G1 transition. All right, this step involves exit from quiescence and re-entry into the cell cycle, typically driven by growth factors, not cyclin D, and CDK-RB signaling. Cyclin D primarily regulates the G1S checkpoint, not cell cycle entry from G0. Yes to G2 transition. This phase is controlled mainly by cyclin A CDK2, which ensures proper DNA replication completion. Cyclin D does not function during S phase progression. G2 to M transition regulated by cyclin B, CDK1, which controls entry into mitosis. All right, look here. Where is this B? Cyclin B is working. Cyclin B is here, right? Cyclin B you can see here. Cyclin B is working here before you enter into the mitosis phase. So that is not the answer. What is the super formula? Super formula is you look at some key points and you come to the answer. If you see cyclin D, overexpression, CDK4/6 activation, RB phosphorylation, E2F release, premature DNA replication entry, uncontrolled proliferation, G1 to S checkpoint loss. Super point here is cyclin D1 drives the G1S checkpoint. Overexpression phosphorylates RB and forces cells into DNA synthesis, bypassing normal DNA damage surveillance, causing uncontrolled tumor cell proliferation and contributing to tumorigenesis. Alright, so cyclin Ds, if they are overexpressed, they are the cells are quickly going, quickly going and causing cell proliferation and tumorigenesis. Very, very important question, because they are testing your knowledge of cell cycle. Because without knowing cell cycle, what can you understand? Like, it is everywhere in the pathogenesis. So next question is, 24-year-old woman develops generalized urticaria, shortness of breath, hypertension within minutes after eating a peanut containing dessert. She is immediately treated with intramuscular epinephrine and recovers. Which of the following best describes underlying mechanism of this patient's reaction? Alright, we have like 4 options. Please select the best one. It's a very easy question, honestly, and you can easily answer this question, and we will discuss important hypersensitivity reactions. So the correct answer here is, like, if you are seeing like within minutes of eating peanuts, obviously you are getting type 1 hypersensitivity reaction. Type 1 hypersensitivity reaction happens through D, IgE mediated mast cell degranulation and histamine release. Very, very important, because that is one of the most common things you see in clinical practice. Hypersensitivity. The topic here is type 1 hypersensitivity, immediate IgE mediated anaphylaxis. Hypersensitivity reactions are pathologic immune responses that cause tissue injury rather than protection. They are classified, divided into 4 types, based on immune mechanism involved. So this is extremely important. Every year you will get a few questions from this topic. So let us go one by one. Type 1 is immediate IgE mediated hypersensitivity. IgE mediated immediate reaction, minutes. Allergens trigger mast cell degranulation releasing histamine. Examples: allergies, asthma, and anaphylaxis. Anaphylaxis here in type 1. Alright, what is happening? The antigen is going and it is standing on IgE on mast cell surface, and the mediators contained in granules in cytoplasm, these histamine is released. You see histamine released, and the histamine causes this anaphylactic reaction. Okay, and in type 2 we have cytotoxic antibody mediated hypersensitivity. IgG IgM binds cell antigens triggering complement or phagocytosis. Best examples: hemolytic anemia, Graves' disease, myasthenia gravis. Blood cells with antigens on cell membrane, and IgE or IgM antibodies binding to cell surface antigens activating complement or phagocytosis leading to cell lysis. So complement is playing a part here, and you got membrane attack complex composed of C5 to C9 lyses red blood cells, and you got hemolytic anemia. That is type 2. All right, that is also a very important question. And type 3, immune complex mediated hypersensitivity. Immune complexes deposit in tissues triggering complement and inflammation. I told you earlier, systemic lupus erythematosus, post-streptococcal glomerulonephritis, serum sickness, these are like type 3. The antigen is binding to IgG. Antigen antibody complexes form in the blood. Antigen antibody complexes depositing on tissues and the blood vessels, kidneys, activating complement and neutrophils causing inflammation. So these complexes are forming all over the place, and then you have post-streptococcal glomerulonephritis or systemic lupus erythematosus. Then type 4 is a delayed cell type. Extremely important, because every time you do tuberculin skin test, okay, what are you seeing? That would be a question. T cell mediated delayed reaction, 48 to 72 hours. Cytokines drive inflammation, contact dermatitis, PPD test, graft rejection. So macrophage ingests the antigen, processes it, and presents an epitope on its surface in association with class 2 major histocompatibility complex protein. The helper T1 cell here is activated and produces gamma interferon, which activates macrophages. These two types of cells mediate delayed hypersensitivity. Okay, that is gamma interferon. That's an extremely important thing, because when you do tuberculosis test like blood, what are you looking for? That's gamma interferon. Like T cells, memory T cells from prior TB exposure recognize PPD antigens, release cytokines, and recruit inflammatory cells. Healthcare provider injecting here PPD, tuberculin intradermally into the forearm, and it forms a veil. And we tell the patient, come back in 48 to 72 hours. When they come back, we see the PPD, how much is the size, and based on the size, we say whether they're positive or negative. A localized skin reaction after 48 to 72 hours measured in millimeters, indicating a delayed type hypersensitivity response. So that is about these 4 reactions. Okay. Type 1 hypersensitivity, as I told you, is an immediate IgE mediated reaction that occurs within minutes of exposure to an antigen. During initial sensitization, allergens stimulate Th2 cells. Interleukin 4, interleukin 13 leads to IgE production, which binds to Fc epsilon R receptors on mast cells and basophils. Upon re-exposure, allergen cross-linking of IgE triggers rapid mast cell degranulation, releasing histamine, leukotrienes, prostaglandins, leading to vasodilation, leading to hypotension. Increased vascular permeability leads to urticaria and edema. Bronchoconstriction causes wheezing and dyspnea. This mechanism explains anaphylaxis, as seen in this patient after peanut exposure. Why epinephrine, all right, is life-saving. In India, we call noradrenaline. So if you see noradrenaline in NEET, that is the same thing. In USMLE, you don't find noradrenaline, because in the United States, they use epinephrine. So you see epinephrine in the United States exams like USMLE. In India, you will see noradrenaline. So you need to remember that difference. The super mnemonic here, that is, how do you remember? The best thing is acid. Acid. Type A is anaphylaxis, and then type 2 is cytotoxic antibodies. I stands for immune complexes. D stands for delayed. All right. Type 1, type 2, type 3, type 4. IgE, mast cells, type 2, IgG, IgM cells, and then deposited complexes and T cells. So very, very, very important. Remember those. That mnemonic, acid for all four hypersensitivity reactions. Now, let us see the options. IgG antibodies binding to self-antigens leading to complement activation. So this describes type 2, all right, antibody-mediated cytotoxic hypersensitivity, where IgG, IgM target cell surface antigens, autoimmune hemolytic anemia, Goodpatcher syndrome. It does not cause rapid mast cell degranulation or anaphylaxis. CD8 T cell mediated cytotoxicity causing tissue necrosis. This is cell mediated, all right. I told you T cell mediated. This happens in a type 4 or cytotoxic T cell mediated injury. Like for example, you are wearing a nickel ring or PPD test. Seen in graft rejection or type 1 diabetes, it develops over days, not minutes, and is not IgE mediated. Another clue to IgE mediated things that they happen quickly. Just like a fly, an yellow jacket, bite me, I ate peanuts. These sort of things create anaphylactic situations. Then immune complex deposition in small vessels with complement activation. This represents type 3 hypersensitivity where antigen antibody complexes deposit in tissues, lupus, serum sickness, post-op GN. Symptoms are subacute rather than immediate. So what is the super formula? Super formula is you look at specific words, okay, these keywords, and within few seconds you go to your answer. For example, when you see IgE bound to mast cells, when you see IgE and mast cell degranulation is happening, histamine is released, bronchospasm happening, then it is type 1 hypersensitivity. All right, that's like, see, using those few keywords you can go to your answer. So super point here is type 1 hypersensitivity is an immediate IgE mediated reaction in which allergen cross-linking of mast cells triggers rapid histamine release causing vasodilation, edema, bronchospasm, and hypotension. All right, folks, that's an extremely important question. Please spend time to get those four things right. That's very important in immunology, also important in other areas like allergic disorders and even clinical medicine. Let's go to the next question. A 28-year-old woman presents to the clinic with complaints of fatigue, joint pain, and a photosensitive rash on her face that worsens after sun exposure. She also reports episodes of painless oral ulcers. Laboratory studies reveal anemia, proteinuria, and elevated serum creatinine. Further testing shows positive anti-nuclear antibodies, anti-double-stranded DNA antibodies. Which of the following best describes the underlying pathological mechanism of this patient's condition? So please take a few seconds and answer this question, and then we will discuss. So basically, I mean, if you look at the case, she has a fatigue, there is joint pain, photosensitive rash on her face, anemia, proteinuria, serum creatinine elevated, positive anti-nuclear antibodies, double-stranded DNA antibodies. So we already know the diagnosis. She has a systemic lupus erythematosus. The question is, what is the pathogenesis of systemic lupus erythematosus? The answer here is a C, because it's I already discussed it in the last question. Immune complex deposition leading to complement activation and tissue damage. Okay, so the topic here is systemic lupus erythematosus, immune complex mediated autoimmune disease. Systemic lupus erythematosus is a chronic multi-system autoimmune disorder characterized by a loss of self-tolerance, production of autoantibodies against nuclear antigens, ANA, anti-double stranded DNA, anti-Smith antibodies. These antibodies bind circulating self-antigens to form immune complexes which deposit in tissues such as the kidneys, skin, joints, serosal membranes. The deposited immune complexes activate complement cascade, recruit inflammatory cells, trigger type 3 hypersensitivity mediated tissue injury, leading to manifestations such as photosensitive malar rash, arthritis, arthralgia, oral ulcers, cytopenias, glomerulonephritis, proteinuria, creatinine. So, systemic lupus erythematosus is extremely important because it is extremely common. So, they are expecting you to know what is happening in the pathogenesis. Systemic immune complex deposition disease causing complement mediated inflammation and organ damage. How do you remember? The mnemonic I use is SOAP brain MD deposits 3 complexes. All right. SOAP brain MDs. S for serositis, O for oral ulcers, A for arthritis, P for photosensitivity, B for blood cytopenias, R for renal disease, A for ANA and anti-double stranded DNA, I for immune complexes, and N for neurological symptoms, MD for malar rash and discoid rash, 3 complexes, type 3 immune complexes. All right. So just put that memory. SOAP brain MD deposits 3 complexes. If you remember that one mnemonic, it helps you a lot. All right. SLE signs plus antibodies, type 3 immune complex deposit disease. What about the incorrect answers? A. Autoantibodies against acetylcholine receptors leading to impaired neuromuscular transmission. And we know that is myasthenia gravis, type 2 hypersensitivity. Causes fluctuating muscle weakness due to postsynaptic ACH receptor blockade, not systemic immune complex mediated organ damage. What about B? CD8 T cell mediated destruction of pancreatic B cells. And we know that is type 1 diabetes, which is type 4 hypersensitivity. T cell cytotoxicity causes insulin deficiency and hyperglycemia, not multi-system findings like rash, nephritis, and cytopenias. What about autoantibodies? Autoantibodies against TSH receptor stimulating excess thyroid hormone production describes Graves' disease. Type 2 antibody mediated stimulation leads to hyperthyroidism, tachycardia, weight loss, heat intolerance, not immune complex deposition or renal involvement. So the super formula is about how to go to the diagnosis using a few keywords. If you see these words like anti-nuclear antibodies, anti-double stranded DNA, circulating antigen antibody complexes, immune complex deposition, and type 3 hypersensitivity, they are talking about systemic lupus erythematosus. So the super point here is systemic lupus erythematosus is a systemic autoimmune disease in which immune complex deposition causes widespread tissue damage through complement activation and inflammation. All right, folks, that is very, very important question. Next, we are looking at a 42-year-old man undergoes an allogenic bone marrow transplant for treatment of acute myeloid leukemia. 2 weeks later, he develops a generalized maculopapular rash, watery diarrhea, and jaundice. A skin biopsy shows lymphocytic infiltration with apoptosis of epidermal cells. Which of the following best describes the underlying pathologic mechanism in this patient? So we have like 4 choices here, and go ahead and choose the best answer. So the correct answer here is B. Donor T lymphocytes reacting against recipient tissues causing widespread inflammation. So what is this? What is the topic here? The topic here is graft versus host disease. Donor immune cells attacking the host transplant. Okay. So here the transplant pathology involves two major immune processes. Okay. Very, very important. First, graft rejection, host versus graft rejection. This is the recipient's immune system attacks the donor tissue. So the recipient is the attacker. All right. So what is happening? The types here are hyperacute, minutes to hours, preformed antibodies. Acute comes days to weeks, T cell or antibody mediated. Chronic, months to years, vascular fibrosis and progressive graft loss. Then graft versus host disease occurs after bone marrow transplantation where graft contains immunocompetent donor T lymphocytes. So that's very interesting and very important to understand the pathogenesis of acute graft versus host disease. All right, please take time to understand that. Like let's give this bone marrow, then you have donor T cells, and then here is the recipient here, and recipient T cells are coming from the other side, and donor T cells are coming from this side, and there is the mismatch between HLA proteins between donor and recipient. So the MHC here and HLA here, they are not matching. All right. So what happens? There are production inflammatory cytokines, right? Tumor necrosis alpha, factor alpha, and interleukin 1, and they produce cellular and inflammatory effectors. And then we have skin problems, we have liver problems, we have gastrointestinal system problems. So three most often affected systems. All right, that's an important question. Skin, liver, gastrointestinal system. So that is what happened in this patient. He has a rash, he has a jaundice, and he has diarrhea. So you see, skin, and then jaundice from liver disease, and diarrhea from gastrointestinal disorder. So all three happened in this patient because of that acute graft versus host disease. And the pathogenesis is donor T lymphocytes reacting against recipient tissues causing widespread inflammation. So that is the mechanism. Donor T cells recognize recipient as foreign. Cytotoxic T cell activation, cytokine release happens, widespread epithelial apoptosis and inflammation happening. Classic organs, skin causing maculopapular rash, GI tract causing watery diarrhea, liver causing jaundice. There's a patient who develops rash, diarrhea, liver dysfunction weeks after bone marrow transplant has acute GVHD. So you need to know what is what, okay? For example, in rejection, who attacks whom? The host is attacking the graft, right? You got that organ, okay, and you are attacking that graft. The timing is variable. And what happens? The graft failure happens. Like for example, if you got a kidney transplant, that's going to fail. If you got a heart transplant, that's going to, if you got a lung transplant, that's going to, if you got a skin transplant, that's going to fail. That is rejection, where host is attacking the graft. Whereas in graft versus host disease, the donor, the donor, is attacking the host. And this is usually happens weeks, and rash, diarrhea, jaundice happens. So the mnemonic here is graft versus host disease. GVHD gives you GDHD. That's how I remembered it. GVHD gives you DGHD. That is donor T cells give harmful damage. D for donor T cells, G for GI tract, H for hepatic injury, and D for dermatitis. So donor cells damage the tissue. What about incorrect answers? A. Host cytotoxic T cells recognizing donor MHC antigens, and host is attacking, right? So we say that is acute cellular rejection, which recipient's T cells attack the transplanted graft. This is host versus graft, not donor versus host disease. What about preformed host antibodies acting against donor epithelium? This describes hyperacute rejection caused by pre-existing anti-ABO HLA antibodies leading to rapid thrombosis and graft necrosis within minutes to hours, not delayed rash, diarrhea, liver injury. What about D? Chronic antibody-mediated vascular injury represents chronic rejection characterized by progressive intimal fibrosis and vascular narrowing over months to years, not the acute systemic symptoms seen after bone marrow transplant. And super formula is about looking for the keywords and going to the diagnosis. For example, if you see these words: bone marrow transplant, immunocompetent donor T cells, recipient antigens recognized as foreign, and donor T cell attacks and skin, liver, GI. All right. So if you see that one word, donor T cells are attacking skin, liver, gastrointestinal system, they're talking about acute GVHD. So the super point here is after bone marrow transplantation, immunocompetent donor T cells attack recipient tissues, producing rash, diarrhea, jaundice, the classic triad of acute graft versus host disease involving skin, liver, and GI tract. So that is a very, very important, because almost every year you will get definitely one question on the pathogenesis of transplant rejection or graft versus host disease. So please take time to understand this pathogenesis. All right. Let us go to the next question. A 50-year-old man undergoes kidney transplant for end-stage renal disease. Poor guy is only 50 and he is already having end-stage renal disease. 5 years later, he represents with the progressive hypertension and worsening renal function. A biopsy of the transplanted kidney shows interstitial mononuclear cell infiltrates, intimal thickening of blood vessels, and interstitial fibrosis and evidence of ischemic hypertrophy. Which of the following best describes the underlying pathologic changes in chronic rejection? So, in fact, I would say this is a poorly written question, because they already gave you everything to know. The answer already is given in the question stem itself. So the answer here is C. All right. Basically, what is happening in chronic rejection? Chronic transplant rejection, progressive fibrosis, and vascular narrowing. All right. We are going to edit that question in the coming weeks on our website. Transplant rejection refers to immune-mediated injury of a donor organ by the recipient's immune system. Rejection is classified by timing and mechanism into hyperacute, acute, and chronic forms, each with distinct pathology and clinical presentation. So when does chronic rejection happen? It occurs months to years after transplantation and represents a slow, progressive immune-mediated process that ultimately leads to graft failure. Unlike hyperacute or acute rejection, which are inflammatory and abrupt, chronic rejection is characterized by progressive vascular remodeling and fibrosis. The fundamental mechanism involves persistent low-grade T cell-mediated and antibody-mediated injuries, smooth muscle proliferation and intimal thickening of graft vessels, luminal narrowing, chronic ischemia, interstitial fibrosis, and parenchymal atrophy. So histologically, this produces vascular intimal thickening, interstitial fibrosis, mononuclear infiltrates, ischemic tissue loss. Clinically, patients present with gradual graft dysfunction, hypertension, rising creatinine years after transplant. So chronic rejection is slow scarring, vascular narrowing, ischemia, and graft failure. How do you remember this? This is the mnemonic you can use. Chronic grafts get clogged. Alright, chronic grafts get clogged. C for chronic. It is already there. Chronic graft, chronic. And L for luminal narrowing. Alright, L for luminal narrowing. There is intimal thickening and luminal narrowing. O for ongoing ischemia. G for gradual fibrosis. G for graft dysfunction. E for end organ atrophy. D for delayed failure. Right? So remember that particular mnemonic, and you can easily reproduce the most important salient features about chronic rejection. Why not A? Acute neutrophilic infiltration with fibrinoid necrosis. This pattern reflects hyperacute rejection, which occurs within minutes to hours due to preformed antibodies causing complement activation and vascular thrombosis, not the slow progressive fibrosis seen years later. However, B, lymphocytic infiltration with tubulitis and endothelialitis. These findings are typical of acute cellular T-cell mediated rejection, which develops days to weeks after transplant and presents with active inflammation rather than chronic scarring and vascular narrowing. Then D, preformed antibodies with thrombosis. Pre-existing anti-donor antibodies cause hyperacute rejection, leading to immediate graft ischemia and necrosis from widespread thrombosis, not the gradual decline observed in chronic rejection. So, these transplant rejection, remember important things about every reaction. Alright, for example, hyperacute rejection, you have preformed host antibodies against donor epithelium. It happens minutes to hours after transplantation. And you see organs cyanotic, mottled, flaccid. Microscopically, you will see endothelial injury, widespread thrombosis, fibrinoid necrosis, neutrophils in arterioles, parenchymal infarcts. Then acute cellular rejection, host T lymphocytes attacking graft, days to months. Microscopically, you see interstitial mononuclear infiltrate, lymphocytes, macrophages, edema, interstitial hemorrhage, endothelialitis, swollen endothelial cells with lymphocytic attack. Then acute humoral antibody-mediated rejection, host antibodies against donor antigens causing complement activation. You will see necrotizing vasculitis, neutrophilic infiltrates, fibrinoid necrosis, and parenchymal infarcts. All right. And in chronic rejection, which we have seen today, you see these words like vascular, intimal, thickening, interstitial fibrosis, mononuclear infiltrates, progressive ischemic atrophy, parenchymal loss. So, how to identify it is chronic transplant rejection when you get a question? That's where super formula helps you. Super formula, when they say there is a history of transplantation, that is a good clue. All right, something happening with the transplant. All right. Then when they say intimal vascular thickening, there is progressive neuronal narrowing. There are chronic lymphocytes. There is interstitial fibrosis. There is ischemic parenchymal atrophy. Okay. So if you see those keywords, the answer is chronic transplant rejection. So super point here is chronic transplant rejection is slow progressive graft failure caused by vascular intimal thickening and interstitial fibrosis leading to chronic ischemia and parenchymal atrophy months to years after transplantation. So those are the questions I wanted to discuss with you, and there are more to discuss. Come back in the next episode. We will have another 1 hour of pathology. You see, pathology is very, very important. Throughout your clinical career, you need to know pathological basis, because without understanding pathology, you cannot really treat any disorder, right? every treatment is geared towards pathology. Every diagnosis is geared towards pathology. Even laboratory medicine is geared towards pathology. That's why you need to understand pathology. Pathology is so important for your examinations. And visit our website. You can literally do hundreds of questions on pathology on our website, www.superpoints.ai, and thousands of questions are also we are going to post soon on our website. Please check on our website. Okay, and if you have any questions, please leave in the comment section. Whether you are preparing for USMLE, NEET, is the same thing because this is science. Wherever happens type 1 reaction, whether whichever test in whichever country you are taking is the same thing, right? That's why there is so much cross material. That's why everybody can be benefited from these lectures. All right. Thank you so much, and I will see you in the next episode.